Good evening and welcome to blackdoctor.org. I'm your host, Shamika Rhymes, and we're so glad you're joining us tonight. Make sure you drop in the chat. Let us know where you're watching from. And if you have any questions, make sure you drop that in the chat as well, and we'll try to get to your questions. And make sure you share this with your network. November is Alzheimer's Awareness Month. So tonight we're shining a light on this important issue. Alzheimer's disease and dementia affect millions of families, and it's crucial to understand the impact that these conditions can have on individuals, especially in communities of color. So, we're going to talk about the latest research, treatment options, and ways to support those affected. So, again, make sure you let us know where you're watching from in the chat. So, let me introduce you to tonight's panel. We're joined by an expert panel of doctors who are going to help navigate this conversation. So, Dr. Thomas Hammond is a neurologist with Marcus Neuroscience Institute at Baptist Health South Florida. Dr. Michael McDermott is a chief medical executive at Miami Neuroscience Institute, which is also a part of Baptist Health South Florida. Welcome. And Dr. Mitzi Gonzalez, she's a board certified neuropsychologist at Cedars-Sinai. So welcome to you all. Thank you for joining us. So I think we're going to start. Oh, I see. I've got some people tuning in from Florida. Welcome in the chat. So we're going to start the conversation off with kind of talking about the difference between Alzheimer's and dementia, because I think sometimes people think they're the same thing. So Dr. Hammond, I'm going to start with you with this one. What is the difference and why is it so essential to distinguish the two?
Well, people have the idea that they're the same thing exactly, except for they're not. Dementia is the umbrella that covers the spectrum of diseases, actually, that are decline in cognitive function over what normally happens with aging. Now, where none of us are getting smaller, it seems the brain starts losing cells after about age 30. So, and so your brain shrinks or atrophies a bit over the course of time, and what's expected of you over time is not exactly the same. So that there's the normal aging process, but dementia is the loss of cognitive abilities beyond what normal aging should do. So the loss of memory, the loss of ability to perform tasks that you used to do, the lack of ability to perform more than one thing at once, so it's multitasking, that kind of stuff. That's the dementia, but it breaks down into the Alzheimer's disease is probably the most common form of it. It's about 60 or 70% of patients who have dementia have Alzheimer's, and it used to be considered early onset and late onset. It's actually all pretty much the same disease. There are some genetic factors that play a role, but there are abnormal proteins that build up in the brain, in the cells, and in between the cells, and you lose brain cells. And Alzheimer's is first and foremost a memory disorder. People start having troubles recalling things that they used to know, and remembering how to do things they used to do, like operating electronics. Usually the remote controls fall apart first, or they confuse their phone and the remote control. That kind of thing happens. The next common is vascular dementia. That's under the umbrella. There's the vascular dementia group. Those are people who have multiple little strokes, and silent strokes are fairly common. We've come to realize that actually when MRI came out in the late 80s, we realized that a lot of people had silent small vessel strokes, and they were mostly in the white matter of the brain. And there was a big debate whether white matter matters because a lot of this was going on. But it turns out the more of those little small vessel strokes you have, the more likely you have troubles with cognition. So vascular dementia is part of that little strokes, and oftentimes that's happening kind of behind the curtain. We don't know that you're even having it. There's a thing called Lewy body disease, which is really a Parkinson's disease variant of dementia, where a lot of visual troubles happen, visual spatial. They see hallucinations. They see people that aren't in the room, or they get delusions, ideas that things are going on that aren't. There's frontotemporal dementia, is one where the frontal lobe of the brain seems to atrophy more so than the other parts. It's a different pathology than Alzheimer's disease, and a lot of times there's behavioral issues there. They can be disinhibited. They can act badly. I had a patient who was a jeweler, and he'd be waiting in my waiting room, and he'd go around telling people how cheap their jewelry was. It was never popular. He got banned from being at one of the malls because he would walk around telling people how poorly the jeweler over there did at that. He also liked to pick up people's babies and and hold them. This was not a popular thing to do, but this was called disinhibited behavior. It's part of the frontal lobe dementia process where they do things that they'll say things that are inappropriate. But that's the frontal temporal growth. Mixed dementia is where there's more than one pathology going on. And actually, if you look at people who are over the age of 85, that's by far the commonest problem, is that there's a little bit of Alzheimer's, there's a little bit of stroke disease, and maybe a little bit of Lewy body pathology in the mix. There are people who have traumatic brain injury can have dementia from that. We're going to see more people coming back from Afghanistan and Iraq and all those places where they've been. They've had head injuries, and or the football players and all that stuff. The sports injuries where they have it. There's some rapid dementias. There's a thing called Creutzfeldt-Jakob disease, which is the mad cow disease. People have heard of it from that cow, but that's a very rapidly progressive cognitive decline. People lose their cognitive abilities rapidly over a course of months, not years. Whereas Alzheimer's and frontotemporal dementia and the others are a process that's more insidious. Anyway, dementia is the whole umbrella, covers the whole package, and Alzheimer's disease is the commonest version of it.
Okay. So is it kind of, I'm trying to process it, but is it, like you said, it's the umbrella, but is it kind of, so if someone's diagnosed with early onset, it isn't quite clear if it's going to end up being one of the ones under the umbrella?
Well, early onset is usually, they talk about early onset Alzheimer's disease, which is usually under the age of 60 or something like that. And in which case you're more likely to have a genetic version of it. Mm-hmm. Like the Downs syndrome, which is the trisomy 21, you end up with 3 copies of the 21 chromosome. They develop Alzheimer's disease very early in their existence. And it's because the amyloid precursor protein is on that gene. That's the one that produces amyloid, which is this protein that's building up in the brain, which we think plays a significant role in Alzheimer's disease. And those people, since they have 3 doses of it, are overproducing Alzheimer's protein in their brain, or amyloid protein in their brain, and they may develop Alzheimer's disease in their 30s and 40s. So that's an early onset, and whereas we're accustomed to seeing a grandpa who's 85 gets forgetful and forgot how to put on his pants and stuff like that. That's late onset Alzheimer's disease. But if you look at the pathology, it's very similar there. They have this amyloid protein and tau protein in the cells and so forth. So,
okay, thank you. Mitzi, I wanted to ask, how does Alzheimer's disproportionately affect certain communities, especially Black Americans, and what may be some contributing factors?
Yeah, that's a great question. So every year, the Alzheimer's Association, they put out a facts and figure document. It's freely available. Anybody can look at it. And they get a lot of epidemiological data. And so according to the data that they've compiled and others, they say that the rate is about 2 times higher in Black Americans as compared to non-Hispanic white Americans. I will say, I do think that there is still a dearth of data. There's a really amazing researcher at Rush University. Her name is Lisa Barnes, and she does a lot of research in the space. And one of the things she says is it true, or do we just not have enough data? Because we need to have good data. This is so important, why we need to have people of all different backgrounds participate in our research, because our estimates are only as good of our data. And if we're recruiting people in different ways or from, different, socioeconomic backgrounds, it could be blurred. And so I would say, statistically right now, it looks like it's higher, but there has been some debate as to whether that's true in terms of why. So we know Alzheimer's disease, as Dr. Hammond nicely explained to us, is one type of pathology. It's oftentimes comorbid in most cases with also some of that vascular damage in the brain. And we know that things like diabetes or midlife hypertension can increase risk of having some of that vascular damage to the brain. And so things like access to care and being able to regularly see, doctors, healthcare manage. We also know about the role of stress too, and how that might be a risk factor as well. And so I would say there's a lot of research that's happening on this topic, and a lot more that needs to be done.
Okay, thank you. I did want to, I'm just throwing a couple other questions in here that, as I'm thinking of them, but is it possible for Alzheimer's or dementia to be misdiagnosed? And that's probably a Dr. Hammond question.
Yeah, there are a variety of things. There are things that masquerade like dementia that are really just encephalopathy, where the brain isn't working well for metabolic reasons. I mean, people have some problem with the calcium. People with hypothyroidism will have something that looks like dementia, but you correct their thyroid and they look better. People with parathyroidism, where the calcium gets screwed up, they'll oftentimes have a lot of cognitive troubles. And if the calcium corrects by removing the overactive parathyroid gland, then they're better. People with renal disease, where the kidney is not functioning well, then people look like they have some kind of dementia process, but it's really a metabolic problem. The brain's not reacting well to the toxicity of things building up. Same for liver disease. So those are things that can be oftentimes corrected by correcting the underlying metabolic condition.
Okay. So I guess we should talk treatments, and I think we can bring Dr. McDermott on this one too. But what are some treatments? I know that there's probably medicines, but then there's also surgery, right?
I'd defer to Dr. Hammond and Dr. Gonzalez first about the medical treatments. The only surgical treatments are experimental, so let's go with the standard treatment first.
Okay. All right.
Well, there is one of the causes for cognitive decline is hydrocephalus, which Dr. McDermott pops into that pile for sure. But these people will oftentimes present as a gait disorder first. They have difficulty with walking somehow or other, and then they lose bladder control somewhat, and then their cognition starts to dip. And when they have that triad, then if their brain imaging shows there's some problem with the drainage of the CSF fluid in the brain, the ventricles get big. Then oftentimes by putting a shunt from their ventricle into their abdomen or into the atrial cavity, you make them much better. And that's a dementia that's treatable, and that's why we're always looking for that one out there. So I have some patients over the years that have done splendidly with that.
Yeah, we frequently get referred patients to go to a screening clinic, and if the major complaint is memory problems, we're immediately suspicious that this is not normal pressure hydrocephalus, but rather one of the dementias. We don't routinely shunt these patients if the predominant symptomatology is gait disturbance and bladder control. What we do is do physical metrics of gait. Their ability to walk 30 feet, we count the number of steps, time them, their ability to turn 360 degrees. We do a Montreal Cognitive Assessment Score, and then we'll do a large volume cerebrospinal fluid tap. So we'll remove 35 to 50 cc's of cerebrospinal fluid, and then 20 minutes later, we'll retest the patients in the ambulatory surgery center and do exactly the same testing. And if there's a 20% improvement or greater than 20% improvement in their gait metrics, then we'll consider that they might be somebody who would respond to a permanent shunt. And usually the effect of that large volume tap lasts for anywhere 24, 36, 48 hours. And then the patients note that they return back to their impaired baseline.
Okay, thank you. Dr. Gonzalez, do you want to add anything about like medication or what other options you provide as far as treatment?
Well, I'm a PhD, I'm not an MD, so I don't describe. So I will defer to Dr. Hammond on that question.
Okay.
Well, for years there was hope, and we still used drugs that modified transmitter systems, neurotransmitter systems in the brain. The major success in that whole story was Parkinson's disease, where A little nucleus in the midbrain is dying off, and it produces dopamine as its neurotransmitter. And if you give extra L-dopa, which is a precursor to dopamine, the Parkinson's patients look dramatically better. And I have this wonderful video I show in my lecture on Parkinson's disease to the medical students, where it's a guy, patient number 3 in the trial at Columbia Presbyterian back in 1968, and he looks just horrible. He's shaking and he can't get out of the chair and he falls over and he can barely move. And after 6 weeks of levodopa, the guy looks like another person. It's the movie Awakenings, by the way. It's a wonderful movie with Robert De Niro and Robin Williams back in the 70s or 80s. At any rate, but that success in treating Parkinson's disease led to the hope that Alzheimer's disease, where there was a problem with the memory circuitry in the brain, and there's acetylcholine neurocircuitry that goes from the frontal lobe into the temporal lobe, that seems to be dying off in Alzheimer's disease. And the hope was that we could boost this acetylcholine receptor system somehow or another and make the disease better. There was back when I was in neurology training and having to take board exams, I was taking extra choline to try and boost acetylcholine in my brain. Should like boost up the memory function a little bit, but anyway, that was one strategy. But the earliest drug was Cognex, which came out in I think the 80s, which was a cholinesterase inhibitor, boosted acetylcholine in the brain. And it was the first of our drugs. It was a cumbersome drug. It had to be given 3 or 4 times a day, and you had to check the liver every week because the liver functions could go wacko. But it made a difference, actually. The people became less apathetic and it came out of their shell, and their memory was a bit better. So it was actually the first drug out of the blocks. Now, after that came 3 other drugs: Exelon, which was rivastigmine, Aricept, which is donepezil, and Razidine, which is galantamine. Those 3 drugs all work on cholinesterase, blocking cholinesterase, increasing acetylcholine in the brain, increasing memory. And they've been really our standard for many years. The drug that got used most often in Europe was memantine, which the FDA encouraged Forest Labs to bring over to this country because we had 3 drugs that all did the same thing, and we didn't have that one that the Europeans were using all of the time. And that one, as it turns out, blocks glutamate receptors in the brain. Glutamate is another neurotransmitter which is going wacko in dementia. Glutamate seems to be increasing in the brain as we're getting older. We don't think that's doing you any good. So blocking glutamate receptors seems to have some benefit, and so that's how that drug seems to work anyway. It got brought over and got marketed as Namenda by that pharmaceutical company, and they were no dopes. They combined it with donepezil and called it Namzaric. So you had a twofer, which was worth a bit of money too. So big pharma is always looking for that. At any rate, the drugs did have some benefit, and they've been our mainstay of therapy for Alzheimer's disease over the last 20 years, really. In the past 3 years, there's been a whole new strategy that's come out. Now, the research for they've been drugs trying to modify amyloid, which is this sticky protein that's building up in the brain, and trying to remove that or slow its production. The drugs that have worked on altering production of amyloid in the brain have all been failed trials, so it hasn't been a rip-roaring success story. The early drugs to give to try and remove amyloid by giving amyloid antibodies, which is the exciting thing right now, but the early drugs giving amyloid antibodies were a hard thing to tolerate because you're giving an antibody to the protein in your brain by an infusion, and people have to come in and get the infusions all the time. But an antibody reacting with an antigen causes inflammation, and inflammation in your brain is encephalitis. So we're giving you a low level of encephalitis for some period of time to try and clear out this junk that's in your brain. Encephalitis gives you headaches, nausea, vomiting, all this stuff. Like the early ones, the first generation of these things were miserable drugs. I was involved in a couple of the trials of those things, and the people would tough it out for a year, but they'd be sick as a dog, and sometimes they'll be a little bit better maybe at the end of the day, but it wasn't so good. They have improved them. So in the last 3 years, there are 3 different drugs got approved in that realm of the amyloid antibody strategy, trying to remove amyloid from the brain. And they're Out of the 3 that came out, there are 2 standing. There's a new one by Lilly in the last couple of months, and there was one that's been out for about a year, Leqembi, and they're cumbersome drugs because you have to receive by IV infusion. The one is every 2 weeks. The newest one is every 4 weeks. But you're committing yourself for 18 months. You can't decide to take a trip to California and spend 3 weeks visiting your kids. You're getting an infusion every 2 weeks. You have to kind of commit yourself to doing these things. But they do remove a large amount of the amyloid that is built up in the brain. So it's a whole new approach to the disease.
Okay, thank you. I was going to bring up clinical trials since you mentioned the earlier trials. Are there any new ones currently going on that those interested may be able to talk to their doctor about?
There's always research in this field. I mean, there's a variety of things there's some things that are approved in China that haven't come here yet. They're in trials. It's hard to say what the next big thing is. The 2 new drugs that have come out in the last year is the excitement at the moment, and deciding who's really eligible for it. Actually, if you had to pick the whole group of people that have Alzheimer's disease, that's the only group of dementia that these drugs are worthwhile for. Probably only about 10% of them are really appropriate for this therapy because of side effect profiles or they're already moved along too far in the disease. We've come to the conclusion that if we don't start treating this disease very early, we're going to have troubles, because if you catch somebody, 4 years into it already, where they're already forgetting things more seriously, then, in terms of these scores, like the mini mental status score, which is a 30-point score, if they had to be in these trials, they had to be at least a score of 24 or 22, perhaps in some of the trials to get into the trial. A lot of people, by the time they've hit the mild to moderate stage, are 21. They're already below that point. They're below the cutoff of the trials. So that's a limiting factor of the drugs that are available. A lot of people, by the time they actually hit our awareness that things are going bad, and that may be a bigger problem in the Black community, because the people don't come to awareness as quickly for some reason or other. People are more accepting of the fact that, oh, grandpa's just getting forgetful, that kind of stuff. We have to probably bring awareness to the fact that not everybody gets forgetful as you get older. The awareness of the disease has to increase somewhat to make these things more effective and capture people early in the disease process.
Okay. Dr. McDermott, are you aware of any clinical trials that you could talk about?
Yeah, we're one of the participating sites in a multi-center trial using low-intensity focused ultrasound to transiently open the blood-brain barrier, with the thought that this might help clear some of the tau or amyloid protein. There was a recent publication, New England Journal of Medicine, which many of us thought was a little premature, but it was 3 patients. It showed that the treatment in various parts of the brain was safe. It reduced the beta amyloid as measured by beta amyloid PET scanning, positron emission tomography scanning. It wasn't a study to look at the cognitive effects, which is ultimately the goal, but we're participating. The trial is funded by the state of Florida. It's an expensive trial, as you can imagine, with follow-up for 5 years. 25 patients is $1.25 million in costs. We've screened about 14 patients so far, and as of yet, we've not been able to treat a patient. But hopefully things will change. And one of the restrictions on patients entering the trial is if they're on some of the new monoclonal antibodies, they're not eligible for the trial. And most of the patients who are aware of the recent trials are interested in this, and then they find out that they're not eligible because of the drug that they're already on. So, but we're hopeful that we can do that. It's done in cooperation with one of my psychiatrists, Patricia Junquera, out at Florida International University, and Dr. Hammond and Dr. Glebus up at Marcus are aware of this and send us patients for consideration. The other things that we're in the planning stages for, and Mitzi and Thomas might be interested in this, is two different trials. One, autologous mesenchymal stem cells derived from fat. One of my colleagues, actually in California, completed a 10-patient study of toxicity and appeared to be tolerated well. These 2 million cells are injected once in that study into the ventricle, or 4 million. And the cells are derived from the patient's own fat. And so it's not considered by the FDA to be a drug per se, because it's the patient's own cells. So that allowed the trial to get underway, and we've been asked to help with participation in that trial. We're interested. And then there's a second trial in progress with colleagues in the United States and Europe, primarily Netherlands, where we're looking at two different dose schedules for whole brain irradiation, 5 days, 75 gray or 180 gray times 5. And we know that similar to low intensity focused ultrasound, the irradiation actually opens the blood-brain barrier transiently for 24 hours. So the same theory that it would, allow for clearance of tau or beta amyloid. And one of the things that Dr. Gonzalez might talk about is we know that in therapeutic radiation for things like brain metastases, much higher doses of whole brain radiation therapy cause impairment of cognitive function. So we try not to use that form of therapy for brain cancer, for example, as much anymore as we used to. So it's a bit of a paradox that we're using a treatment in a lower dose that's been known to be associated with cognitive decline later on in a higher dose. But, we don't really have any effective treatments to date. It's a little bit frightening about the coming tsunami of patients. It's estimated that the number of Alzheimer's patients will increase by, 5 million to 10 million every 10 years. And by 2050, there'll be 150 million people with the disorder. So we better develop Operation Warp Speed for Alzheimer's like we did with, the COVID pandemic. So we're working away at it, trying to solve the problem.
Okay,
Can I add just a little bit?
Sure.
Yeah, so all these are great and very interesting. The other thing, and Dr. Hammond mentioned this when he was speaking too, that we're learning more and more that the earlier we start treatments, the better. In fact, when they've done some of these anti-amyloid trials, they've seen, if they look at the groups separately based on disease progression or based on the levels of some of these proteins in the brain, that it's the people in the earlier stages that are benefiting the most. And so there is an ongoing trial called AHEAD, and the goal of that study, it's using some of these anti-amyloid treatments, but starting them in people that have the elevated amyloid in the brain but are cognitively normal. And because we know that the amyloid protein buildup starts about 2 decades before we start seeing any symptoms. So starting early, and we're having new ways for detection. So that's also really exciting. There's also been a lot of therapeutic development still very much in the early stages of targeting the other protein that Dr. Hammond mentioned, the tau protein. And so unlike amyloid, the tau protein is actually in the neurons themselves. And tau deposition is more closely linked to cognitive decline than amyloid. And so there are new trials also looking at that approach. And more than anything, while the anti-amyloid treatments hasn't been as effective as anybody, I think, initially hoped, what it has done is it's shown that we can at least modulate some of these proteins, and that maybe amyloid isn't the only thing we should be considering. And so when you look at the number of different therapeutics that are being tested in different pathways, it's expanded greatly. And so I think that there will be more and more opportunities for trials, different types of trials targeting different types of potential pathologies, and certainly moving earlier, I think is going to be very helpful.
Thank you. With that, how important is early detection, and what are those measures to, do the early detection? Is it just an MRI or a CT scan? And what signs should people look out for in themselves or their loved ones? And any of you can answer that one.
Well, one of the issues that's out there is genetics. We've known for probably the last 15 or 20 years that there's this one gene that predisposes to Alzheimer's disease. We haven't been routinely testing it because we didn't have a strategy to deal with it other than, determining that you're at increased risk for having Alzheimer's disease. It's called apoprotein E. It's an apo enzyme that has to do with processing lipids, but as it turns out, it's very crucially involved in Alzheimer's disease. We all get an apo E2, 3, or 4 from our parents. E1 apparently so rare that it doesn't even count. But the commonest is 3, and you get one of each from each of your parents. So 3 is actually E3. E3 is the commonest one that we all wander around with. Mm-hmm. And that we consider that the average risk of having Alzheimer's disease if you have E3. If you have E2, you got a 2 from both of your parents, you're actually substantially less likely Alzheimer's disease than the average person. If you have an E4, that's the bad one, unfortunately. If you have one E4, you're about 2 to 3-fold increased risk of having Alzheimer's disease. If you have E4, if you got 2 E4s, then we know you're something like 16 times more likely to get Alzheimer's disease. You're like in the 80 to 85% likelihood of getting Alzheimer's disease at some point in your life. Now, you may not develop it till you're 98. And if we test you at 20 and say you have E4, and you're wandering off looking for the bridge to jump off, what have we done? That's the problem. Is we had. I'll preface this with Huntington's disease is a genetic dementia. It's a rare disease. People usually get chorea, which is this abnormal movements. They get some personality changes and so forth, but then they get a progressive dementia, and they're pretty severely affected by the mid 50s or 60s. We've known a genetic test for that since the mid 1990s, and it's a dominantly inherited gene. So if your parent has Huntington's disease, you have a 50% chance of having that disease. Now, since that genetic test has been available in the 90s, it's only about 25% of patients who are at risk for having it want to know. I mean, your father has Huntington's disease. We say, well, you're at risk for having this. You got a 50% chance of getting it. It's a small percentage of people it's a minority of people who want to know because there's no treatment for it. And the sad thing is actually by the time your father has Huntington's disease, you may already have kids, so you've already passed the gene along to the next generation. It's a troublesome disease altogether. But I mean, I use that only as an example. The ApoE4 test for Alzheimer's is sort of the same story. We didn't know what to do with it other than tell you to live a healthy lifestyle. Don't smoke. Don't drink more than 1 drink a day or 2 drinks a day. Don't keep your body mass index under 25. Eat a healthy diet and exercise at least 30 minutes 5 days a week. And for vascular reasons, we want you to keep your blood pressure good and your cholesterol good. So the Life Simple 7, that's what we tell you to do, whether we know what your ApoE4 is or not. And after we know your ApoE4, we're going to tell you the same stuff. So that's really why we've been not doing it routinely. But there is some suggestion that we should be testing that more often, particularly if there's a family history where, and actually it's hard to find a family where there isn't somebody that's got dementia as they've gotten older. So, it may be that we're going to have to look at that more heartily. And if you have those genetics, and actually in the last year, there was another gene discovered in the Black population that makes the E3. If you have the E3 in this other gene, then it makes it more likely you're going to get Alzheimer's disease, even though you have the E3, which is the healthy one. So I think genetics is wandering into medicine in a big way in the last few years, and it's going to move more and more that direction. So we will be looking at your genes to try and figure out where you go, and we'll probably pick people up earlier, and maybe that's when we can modify the tau protein, which is the one we think is probably more important than the amyloid one, but that's where we're going.
Okay, thank you. Dr. McDermott?
Yeah, I think One of the problems running a clinical trial is the inclusion-exclusion criteria, and some of the biomarkers have created a lot of confusion for us because the original description of the disorder was a clinical one, right? So it was constitutional symptoms of forgetfulness, cognitive functioning, executive functioning that gradually failed and accelerated. And then imaging came along, and then we saw atrophy, and now we have biomarkers, but there are many patients who live into their old age who have lots of tau and beta amyloid in their brain, and they're functioning perfectly fine. And what we need to do in these clinical trials is identify patients clinically that have the clinical syndrome of memory failure, the MoCA problems, neuropsychological problems, where we can actually measure stabilization of that problem or an improvement. So, for example, if a patient has a p-tau 217 blood test that's associated with a greater than 80% likelihood of developing Alzheimer's, but they're functioning normally, then it's really a problem for us because somebody will tell them, you have Alzheimer's. And they get very scared because they say, well, I think that I'm doing pretty well. I'm 78 years old. And they do a MoCA test, and the MoCA is 28 out of 30, which, everybody on this panel probably scored 28 out of 30 on a MoCA. And so it's created, unfortunately, a little bit of confusion for the patients and families and difficulties for us to try and explain to the patients that we need some measurable deficit clinically in order to, in the short term, show a benefit from our treatments. Now, Dr. Gonzalez mentioned identification of the disorder earlier. Those trials with medications and the follow-up required to document a reduction in progression disease are going to be prohibitively expensive, really, and they're going to take many, many years to identify a reduction in the rate of progression in patients who are really functioning well at the beginning with just a biomarker. So that's the problem. And by the time some of those preventative studies come to fruition at 10 years, there's another 55 million Alzheimer's patients that are out of luck.
Thank you. Nitzi, did you want to add anything? I think you mentioned earlier something about blood-based biomarkers.
Yes, and Dr. McDermott certainly alluded to that. I think the good thing is that we're really trying to have a multifaceted approach, and absolutely we need new therapeutics, better therapeutics for people in the active symptomatic stage. And we are in this stage now where we can better detect whether somebody has some of these pathologies. And so, as Dr. McDermott said, it's not 100% that everybody that has amyloid by any means is going to develop dementia, but it does mean that they are at higher risk than somebody without. And so I think that just trying to be able to have different therapeutics for different stages of the disease, having some that focus more on prevention, some that focus on active treatment, is really important. And, for a long time, we weren't able to know anything about the pathology in the brain in terms of the proteins that were aggregating, other than, looking at some of the cerebral spinal fluid. Now we have different methods with PET imaging and the blood-based biomarkers, and certainly they're not perfect at this time, but I think it's a big advance for the field, and it's going to be really helpful for us in the future of really reaching what we hope for in all of medicine, is that precision medicine of knowing what are the factors that you have that personally put you at risk from a biological perspective, and how can we appropriately target those.
Okay, thank you.
I think one of the important factors, what Dr. Gonzalez does, is neuropsychological testing has been very useful for trying to determine where people are oftentimes. We do these brief things like a mini-mental status test or a MoCA, which is another, quick look at what your cognitive function is. But, the neuropsychological testing is much more elaborate, and we get a feeling for where you've been lifelong. Are you still functioning at that level? That's a very useful bit of information. We have people come to us who have been very smart. They have an IQ of 120, and they're still better than average, but they know that they're going down, and their family seems to know they're slipping. But it's really the neuropsychological testing that shows that there are a lot of neuropsychometric areas. They're sitting at the 80s instead of 20 where they used to be. They've lost a lot of ground. So I mean that the testing that's done by the psychologists is still a very useful piece of our workup. Volumetric measuring for an MRI has become useful, somewhat more useful too. In the last few years, they've developed this thing. The one we use in our hospital is NeuroQuant, but there's a variety of them. They're quantitative measurements of how thick the memory cortex is, and how thick the whole brain is. The whole brain cortex is, and the white matter, and so forth. And the computer, I have to say, it beats me. I mean, I used to say I could eyeball it and figure it all out, but I mean, these things can tell me that, your hippocampus is at the third percentile for your age, which means, you're losing it probably.
Mm-hmm.
And especially, what I find that volumetric measurement is most useful sequential. If I get it 1 year and then a year later, then person was at the 50th percentile for their age, and now they're at the 3rd percentile or the 20th percentile. I know that they're losing cortical volume at a more rapid rate than other people their age, and that leads us into that direction. These are new things that have come out in the last 5 years or so. These volumetric measurements of the brain. It's useful.
Okay, Dr. McDermott, are there any other methods that can kind of look at functional?
Yeah.
I don't know what word I'm trying to say, but you get where I'm going with it.
Yeah. So even now, about 10 years ago, the NIH funded an international project called the Human Connectome. And what that does is looks at resting state functional MR. So you're in an MR machine, minding your own business, not doing any task-driven functions like, I want you to close your right hand, open and close it 10 times in the next minute. No, you're just lying there. And we can identify up to 6 major functional networks like the default mode network, the dorsal attention network, the salience network. And these networks we've compared quantitatively in patients undergoing whole brain radiation therapy for multiple brain metastases, the people that are going to get the cognitive decline at 1 year post-treatment. And we've showed a very high correlation between neuropsychological testing, quantitative measures, and the human connectome. So the potential advantage is that if the patient is going to have Dr. Hammond's MR scan for the volumetric testing, we can do the resting state functional MR with an additional 7 minutes. And we may be able to get a clue as to their, ability, cognitive correlation, if you will, with the connectome rather than spending 30 minutes doing the neuropsych testing, which may be an advantage for the patient. And it would also give the doctor some clue as to whether or not there's evidence of progression versus stabilization of their condition. So I'm very excited. There's more than 100,000 normal data sets for individuals in the Human Connectome Project. It looks at functional connectivity as well as structural connectivity. And the field has just taken off in the last 4 years. I think that's going to be very important in the future.
Thank you. I know in the comments we've had quite a few questions about what role lifestyle choices can play, like diet, exercise. I saw someone ask about vitamins or supplements. So is there anything that can help, I guess, slow down the progression or even prevent this from even happening, from even developing Alzheimer's or dementia? And anyone can answer that one.
I spend my day telling people to keep their brain active and their body active, to be honest with you. I mean, there's plenty of evidence that exercise seems to stimulate, in brain repair and protect it from bad stuff. I love to give them. There was a rat model for Parkinson's where they give this toxin to the rat, and the rat shakes its hand and it walks in circles. And if you have an L-Dopa, which is our Parkinson's medicine, it looks like it got better. So that's a nice model for Parkinson's in the rat. Well, about 15 years ago, the University of Pittsburgh group took a bunch of rats and they stuck this group in the cage and made them exercise. Maybe they made them run the wheel or whatever those. Anyway, those the exercise rats. The other group of rats sat in the cage and watched TV and drank beer. Okay, so after 2 weeks, they come out and they give all of the rats the toxin. 3 days later, the rats in the cage that were inactive are all shaking their hands and walking in circles. Okay, the rats that were exercised, none of them are bad. So it was 100% difference. It was a very bad day for the rat family because they cut off all their heads. But anyway, and they looked at the brain, and the brain of the rat that exercised lost about 6% of the cells in this little nucleus that's damaged by the toxin. 87% in the non-exercise rats. 6%, 87%. GDNF, which is a growth factor that plays a role in repairing cells, pulling out stem cells, doing all the good stuff in the brain, that was 40% higher in the rat brain than exercise. So I tell this story to my patients. I said, you want to be the exercise rat. That's the moral of the story. You got to do something. You got to get up and move around. You can't be sitting there watching the tube all day. That's not getting you anywhere. So I mean that exercise concept works splendidly in all of our degenerative diseases. If we can get our Parkinson's patients, we can get our Alzheimer's patients to exercise regularly, they seem to decline at a much slower rate. And that's it. In terms of supplements, I mean, they have to eat a healthy diet. I don't know that anything there was a trial that showed that turmeric had some benefit for memory, and that's why I have them try that. 500 milligram of turmeric twice a day. It doesn't bother their stomach. That's curcumin. That's what makes the Indian food yellow, I've been told. So,
Oh yeah.
that's what I recommend anyway.
Thank you. It reminds me of my grandfather. He would always say, you got to keep your mind active. You just got to stay busy doing something. He would just walk around, and he lived to be 95. So he just always kept busy.
Yeah.
Yeah.
It's one of the activity is one of the characteristics of the blue zones in the world, where people live a long life and are active, functional. They socialize. They make their own meals at home, use home cooked food rather than going to the fast food joints. And yeah, I think it's true. That's one of the reasons I kind of don't want to stop working. I know as a neurosurgeon, I can't keep going forever, but I think it's true. If you stop being inquisitive, using your brain to do things, solve problems, ask questions, then it doesn't work the way it used to.
Mm-hmm.
Yeah, I live in South Florida. A lot of people come here. They come to retire, then they don't know what to do with themselves. I mean, there's only some days, so much time you can play golf. Then you got to do something else, right?
I had a 92-year-old real estate developer in San Francisco who went to work every day, Monday to Friday, 10 to 2, 92, got sick with pancreatic cancer, died in like 6 months. But mental functioning was crisp all the way close to the end.
We've all seen it. If people keep their mind active, they do much better.
Uh-huh.
And even when they're showing early decline, I try and encourage them to get involved in whatever, to join a book club. If they were a reader, join a book club, because then they have to read the book. They have to read it at a certain time frame. They have to talk about the book, so it kind of goes over stuff with them. We get them playing puzzles, and there's a million brain games on the computer they can play. But apathy is a major feature of dementia. So they get apathetic. They lose interest in things they used to enjoy.
Mm-hmm.
They lose interest in they talk the talk, but they don't walk the walk. They walk out the door and say, "Oh, of course I'm going to do this," and come back. I haven't read a book in 6 months.
One thing that I'm curious that we've overlooked is omega-3 fatty acid supplements were a big deal 5 years ago. What's happened to that?
I don't know that there's sound, but there was a high dose vitamin E was shown to be very effective in one trial a lot of years ago. Then there was some meta-analysis that said the only thing they could show was that if you ate high dose vitamin D, you're more likely to die than the guys who didn't.
Oh my God.
that was not as encouraging as it had been. But at any rate, we're stuck with the supplement stuff. But people are going to take it no matter what. I just try and guide them a little bit what they're going to do. Okay. Heaven knows I was taking choline before I took my neurology board exams.
Well, I know we're running out of time, and I want to make sure that we address the caregiver question, because that's a lot of people have that question. If there's any advice for those that are caregiving, or they're thinking about getting a caregiver, or at what point do you even think about a nursing home or facility for someone that has dementia or Alzheimer's? And I'm going to open that to any of you.
I think Mitzi should tell us about, the personal stress, the caregiver stress, because it's true for brain tumor patients and all kinds of other conditions.
Mm-hmm.
Yeah, definitely taking care of yourself as a caregiver is so important. We know, unfortunately, that individuals that are caregivers for individuals with dementia, they have higher risk of other chronic conditions, likely because they're focusing all of their time and attention on their loved ones and not attending to their own medical appointments. And, whenever I get with a patient and a family member in the room, I'm so grateful that they have that family member, because that's the person who is keeping them healthy and helping them get through the day to day. So I think us, in the medical world has to really think holistically about the dyad and the care circle, when to place. That's an individualized decision. And there are a lot of factors involved, such as, one, kind of preference, and then two, just based on the level of support. Some people are fortunate and have a lot of family nearby, and people who are able to take shifts, and people who have more flexibility with work. Not everybody is in that situation. And so it depends on how those care needs can best be addressed. And I think it's good for people with dementia to also be involved in their care decisions to the extent possible. And so I encourage people to think about it early. I encourage people, maybe visit a few centers, see what you think. We want that person to be involved, and so we can honor their wishes and preferences. I think everybody should have advanced directives set up. That's hugely important, so that we know that your loved ones are able to know that they're honoring your wishes. The other thing I'll just mention briefly is that Medicare Part B has a new program. It's called CMS Guide. Right now, they're just testing it and rolling it out, but it's designed to be a more comprehensive care service for individuals with dementia and their partners, getting a more kind of comprehensive assessment of not only medical needs, but also social needs. And then for patients that are in the more advanced stages, there is also some people may qualify for respite services as well, which is definitely hugely important. So I would say, if you're a caregiver, don't be shy about asking for support and resources. It can be hard to find this information. Local Alzheimer's Association chapters, that's a good avenue to get additional resources, and talk to your physicians and your care providers too, because it's really important.
Thank you.
There are a number of respite care programs in the county around here in Broward County and Palm Beach County. There are a number of adult care programs that are very nicely run, and a lot of times the patient can be picked up by a bus. They take them to the center. They have their lunch there, and there are activities. It's good for the patient because it's a cognitive stimulant. It's actually better than them sitting at home, and it's a respite for the caregiver, so that they have a time off. They have time to themselves when the patient's off at the centers. And I think almost every county now has these things, and just make sure that the patient's relative is aware of it. Now, when you first bring this up with the patient, they're always saying, "Oh, I don't need that," or but sometimes you can get them to go, and after a while they realize they like it, and a lot of the times there's a gradation. The people that are milder actually help take care of the people that are more advanced in the center. So I mean, they actually get to enjoy that. There's sometimes there's artwork they can do. There's things that they may find interesting that they wouldn't have done otherwise. So I think these adult care centers are a very useful means of helping the caregiver as well as the patient.
Mhm. Well, this has been such a great conversation. I have learned a lot tonight, and I've seen the comments that, a lot of people had a lot of questions. So maybe we need to do a part 2 at some point, but this was great. Thank you again for coming on tonight to talk about this important topic. And for everyone else, for more information about Alzheimer's and dementia, you can head over to blackdoctor.org and check out all the articles and resources. And then, of course, some of the resources that were mentioned tonight. Make sure to check those out as well. Thank you again for joining, and have a great night.
You too.
Bye-bye.
Thank you. Bye.